Okay, inshallah, we'll be talking about um, adjuvants in pain medicine and palliative care. This is a very big amount of information, so I have to start a little bit early so we can finish it up. So we're starting with the definition of adjuvants. Then we're gonna go through all of these, group of drugs. Uh, so what is adjuvant? Adjuvant analgesics differ from opioids in important conceptual ways. Number one, adjuvants may or may not elicit pain relief. The nature of the dose response relationship is not predictable. It's not like opioids. With opioids, the higher the dose, you get more pain relief. Okay? Uh, but with an adjuvant, you might or might not. So that's why if it doesn't do the job, you have to switch to something else. And most of the adjuvants are used in neuropathic pain. Um, this is the WHO guidelines. And as you see, the adjuvants are placed in each step of the WHO step ladder here. First step, second step, and the third step. So they encourage you to use these adjuvants in all stages. Okay? The mechanism of action of these drugs, I mean, is beyond your scope, but you have to have some just basics here. So to understand that, you have to learn what is meant by cellular communication. We have cytoplasmic receptors, we have an enzyme systems, and we have a transmembrane protein. The one that we really focusing on is the transmembrane proteins, which are basically voltage sensitive, ligand gated ion channels, and signal transduction. So these are the ones that you need to know, just basics, okay? So you have an idea about these drugs. You don't have to get too much details. And this is basically the lipid, membrane and the transmembrane proteins involved. Okay, another concept that I would like to uh, teach all of you guys is something called number to treat. This is something that's really overlooked and it's extremely important. What is number to treat? It's the number of patients treated to get one with 50% pain reduction. Okay? So the smaller the number, the more effective the drug is. So if you look at the NNT for opioids, for example, is somewhere between 4.3 to 4.7. The NNT for gabapentoids is somewhere between 7.2 to 7.7. And the NNT for tricyclics is 3.6, which tells you that actually tricyclic is the most effective out of these drugs in neuropathic pain. So why we don't use it as a first choice? Because of the side effects. Okay, that's the main reason. So there's another number we're not going to talk about today. It's called number to heart. Okay, and you have to balance between these two. This is just repetition. Number to treat. Okay, as you see here, the TCAs are, number of the number to treat is 3.6. So it's actually the most effective out of these. All right. Next, we're going to talk a little bit about different chemicals in your brain. we have so many chemicals, all right? But the most important ones that you need to know about are these three uh, to begin with: the noradrenaline, the serotonin, and the dopamine. The noradrenaline is the one involved in giving you energy and concentration, okay? And it's involved in pain. Serotonin is more involved in obsessions, compulsion, memory, mood, okay? The dopamine is more involved in the reward and pleasure, interplay sort of. So the drugs that increase the noradrenaline in your brain actually helps with pain, chronic pain. While the serotonin, the drugs that increase your serotonin, in fact, helps you with depression and obsessions if you have like OCD or whatever. And as far as the dopamine, there are drugs that increase dopamine in your brain, such as Wellbutrin, for example. And this is important for a motivation. Antidepressants, they increase your dopamine in your brain and thus they reduce the chronic pain. Examples are tricyclic antidepressants and, of course, other types of antidepressants that increase the norepinephrine, um, you know, will actually reduce your pain or chronic pain. Um, the TCAs are very useful in chronic tension headache, combined with CBT or combined or cognitive behavior therapy. MAO inhibitors are old drugs, used to be like 30 years ago or something like that. And we used to use them in resistant cases of depression. Nowadays, all of them are replaced with, the newer SSRIs because of their, drug and, food interactions. Okay, these are the tricyclic antidepressants. The most famous is amitriptyline. I use it a lot. I don't exceed 25 milligram per day because it's actually you start to get QT prolongation and you can actually cause urine retention in an elderly patient, or you can precipitate a glaucoma attack in anyone, above 70. Um, so you gotta be careful about the usage. But if you're gonna use it like 10 milligram to 20, maximum 25, you're probably gonna be in the safe side. Doxepin is safer than amitriptyline, and nowadays there is a drug, from doxepin is used for sleep, and there is a doxepin cream is used for diabetic neuropathies. These other ones, trazodone, we use it. It's a heterocyclic antidepressant, and it has a special chemical intermediator called MCPP. By the way, this drug is the drug of choice for most doctors, pain doctors, as a sleeping aid. Instead of giving benzodiazepines and get into the problem of combining benzos with opioids, they give trazodone. And it's available in Egypt, by the way. But for in Saudi Arabia, for some reason, it was not approved. Bupropion is the drug I just mentioned that increase dopamine and thus, can increase your motivation. You can use it in, obesity. You can use it in, like smoking cessation and so forth. Mirtazapine is another, a heterocyclic drug that, we love it in palliative setting because it actually increases the appetite of the patients and might increase body weight. Okay, and also helps with sleep. So it's like, it's a great drug. It helps with itching. It helps with breathlessness. So, like in palliative care, usually we use mirtazapine. Now, the SSRIs has no role in pain per se, but they're important for depression, okay, that accompanies pain. All right. And I want to mention something here. Uh, you know, the biggest problem with SSRIs are two things. Number one, drug interactions because they involve with with the CYP450 inhibition, and number two, sexual dysfunction. These are the two major side effects of SSRI, and they do not help with pain. They only help with depression. Okay. Now, on the other hand, we have something called the serotonin norepinephrine reuptake inhibitors, or SNRI. And these folks, guys, help with pain and help with depression at the same time. The most famous one is the Loxetine. Okay. We use them also in cases like fibromyalgia, for example. All right, and diabetic neuropathy. So these are really good drugs. Uh, this is the cytochrome P450, and how they metabolize different drugs. I want to mention that there is one form of the CYP450 called the 2D6, and this is deficient in Caucasians. 8% of Caucasians, okay, and thus these guys might have trouble taking codeine, okay. The most famous is the 3A4, followed by the 2D6, and then 1A2 and 2C19, 8-9, and 2E1, and so forth. Okay, another set of drugs, the azapirones or buspirone. Okay, we use this for mild anxiety, or what we call generalized anxiety disorders, GAD. Okay, they call it GAD. All right, mild to moderate generalized anxiety disorder. It's a good drug, but not used as much for some reason. It's not a PRN medication. You have to take it on regular basis, and it's available in the market with no restrictions. Now, uh, benzos, okay, or benzodiazepine. These are the most famous drugs for anxiety. Okay. Now, I want to say that we have different receptors for the benzos. Okay. All of them are under the umbrella of the GABA A receptor. We have alpha 1, we have alpha 2, 3, and 5. All right. We don't have 4 for some reason. We don't have 4. But alpha 1 is involved in sleep. So we have a set of drugs that work only on alpha 1, and these are the only FDA approved drugs for sleep. We're going to mention them right now. And then we have the rest of the benzos work on both 1, 2, 3, and 5, which the other forms help as an anticonvulsant, anxiolytic, and myorelaxant and amnestic properties, such as Valium, for example. Okay, so these are the benzos. Okay, GABA A receptors. Uh, the shortest acting right now in town is called Remimazolam. Remimazolam, and this is like an ultra short acting drug. And I want to mention, by the way, a country like Belgium, they're using it for palliative sedation, by the way, right there. Okay, we don't. I mean, this is way, way, far away from us, Remimazolam. We use midazolam in the Middle East for palliative sedation. Okay, then you have the rest of the drugs here. You know, the most important is lorazepam because this is the drug of choice for patients with seizures and anxiety. Um, we don't use diazepam a lot, okay, because of its complicated metabolism, okay, but sometimes we use it at home as a rectal form for seizures, okay. Diazepam, again, it's metabolized to something called dismethyl diazepam, which is slightly less potent. All right. Um, Lorazepam and oxazepam are metabolized by conjugation. Anything that's metabolized by conjugation, make sure that this drug is safer than the other drugs that are metabolized by the P450 in advanced liver cirrhosis. Because in advanced liver cirrhosis, the first that's affected is the phase one that involves the P450, while the conjugation is reserved. So if I have somebody with advanced liver cirrhosis coming with alcohol withdrawal, for example, in the hospital, what we call delirium tremens, I've seen tons of these when I was in the United States. So you can use something that's metabolized by conjugation, like such as lorazepam. Okay, and basically there is a mnemonic for it. The lot, the lorazepam, oxazepam, and temazepam, or lot, these are metabolized by conjugation. Okay, now these are the non-benzodiazepine hypnotics, and we just talked about it. They act only on the alpha 1 receptor, okay, such as zolpidem, zaleplone, and isoprene. Okay, all of them are FDA approved for sleep. Okay, however, the main problem is something called sleepwalking. All right, and this is a huge problem. Another sleep aid is called ramiltion or rosiram. This one works in melatonin receptors. Okay, you know, it helps with the sleep, and is involved in the maintenance of circadian rhythm. So I use it in when we have circadian rhythm disorders, and these are basically one section of sleep disorders. It's called circadian rhythm disorder. Then we have doxepin. Remember we talked about it early on, or Silenor, and this is a relatively new agent that we use for sleep right now. Of course, has all the side effects, that of TCA. These are off-label medications used for sleep. Okay, now we'll jump into the drugs that work on the GABA. And something to really know about is most anesthetics, all right, work on the GABA A receptor, like the benzos, barbiturates, propofol, etomidate, and all that. But even volatile anesthetics work on the GABA inhibition. GABA A. Baclofen, the only drug that works on GABA B is the baclofen, and you can easily memorize it. B for baclofen. Okay, these are the clinical uses of benzodiazepines and their conversion. The diazepam, alprazolam, clonazepam, lorazepam. So all of these are, uh, basically, indications for benzos. You know, there is no indication for pain except for only one drug, which is called clonazepam or clonopin, and this is useful in what we call surface allodynia. But the rest of the drugs are used in dyspnea, panic disorders. Dyspnea, of course, as a second agent after opioids. Okay, panic disorders, especially the short-acting, muscle relaxation. All right, anxiolysis before surgery, as an anticonvulsant, delirium tremens, like I mentioned before, from alcohol withdrawal and so forth. Anticonvulsants. Okay, so these are some of the anticonvulsants that we have: carbamazepine, oxycarbazepine, pregabalin, gabapentin. The first choice for neuropathic pain are what we call the gabapentoids. All right, just take it as a rule: the gabapentin and pregabalin. Now, as first choice for trigeminal neuralgia, okay, is carbamazepine or what we call oxycarbazepine, which is basically very near in structure to carbamazepine. It's under the name of triliptan. All right. Topiramate is mainly used for prevention of migraine headaches. Clonazepam, as I told you, for basically surface allodynia in neuropathic pain. I remember a guy in Saudi Arabia. He was like 90 years old and he had post-herpetic neuralgia, one of the most uh, painful neuralgias you ever imagine. And basically, anything will touch, he had it in his neck. Anything will touch his neck, he will just, jump from his chair. So when I use the clonazepam at night, it reduced this surface allodynia, and the patient really did very well. But of course, you have to be super careful with the dosing. The maximum dose of clonazepam, by the way, is 4 milligram per day. All right, carbamazepine, tegretol, in trigeminal. Then we have calcium channel blockers like gabapentoids, gabapentin, and pregabalin. And then we have the L-type calcium channel blockers such as verapamil and amlodipine. Okay, the verapamil is used for cluster headaches prevention, amlodipine and nifedipine for Raynaud's disease. The gabapentoids, we talked about it. There is an intrathecal form of gabapentoids called the ziconotide. Okay, this one. So these are the verapamil, amlodipine for Raynaud disease, gabapentoids for neuropathic pain, working on the N-type calcium channels. Mainly, main side effects is, over sedation, fatigue. Sometimes they cause edema in the lower extremities. Uh, and they get abused, by the way, by some patients. Now, if they got abused and patients took super high doses from them, this can lead to QT prolongation, but it can lead to death. But you need really mega doses of these drugs to get intoxicated. Ziconotide is the intrathecal form of it, and we use it for neuropathic pain, intractable neuropathic pain. Okay, this drug you have to titrate it, very slowly, so you don't get the side effects of these, of this drug, like over sedation, drowsiness, and all these neurologic side effects. It's extracted from a marine snail, okay, called Conus magus. And by the way, this Conus magus is abundant in the Red Sea. For those like in Saudi Arabia and Egypt, I mean, this snail is abundant in the Red Sea. Okay, it's under the name of pre-alt. Okay, another drug. I just put it there because we use it on daily basis. So I wanted to explain it to you. The menthol. Okay, menthol, guys. All you need to remember, it works on this channel. It's some type of calcium channel called the TRPM8. Okay, so it's an antagonist to this TRPM8 calcium channel. All right. I'm sure you've used it one of these days, the Saluna pass or whatever. pain relief patch. Okay, usually they mix it with methyl salicylate, so it's always mixed with the salicylate to get the anti-inflammatory effect. Clonazepam. Okay, the clonazepam, as I told you, okay, it's a benzo. It's the only benzo that is useful in surface allodynia and neuropathic pain. The rest of the benzos, they are not useful in pain. They are useful in other, conditions like, as I said, breathlessness, anxiety, panic attacks, seizures, and all that. One of the major side effects of clonazepam is behavioral alteration. So you have to monitor the patient. If the patient starts to get behavioral changes, you might need to, get off this medication. And I want to stress on the maximum dose. It's 4 milligram. Don't exceed 4 milligram, guys. This is a mega dose for the clonazepam. It's a potent drug. I usually start with 0.25, zero point 0.5. I never go beyond, as far as I'm concerned, I never go beyond 1 to 2 milligrams. I never go beyond 2 milligram by any chance. Valproic acid, its usage in pain is getting less every day, but it's an important drug in seizures. Okay, it can be used for migraine and cluster headaches, but this is not anymore. I mean, this is like redundant. Topiramate is still a very important drug in migraine prevention. It works on a receptor called AMPA. AMPA is something very similar to NMDA. It's a receptor similar to NMDA that the glutamate works on it. Okay, so glutamate, which is the excitatory amino acid in your brain, works on NMDA and AMPA. All right, so this one works by blocking the AMPA receptors. The main problem with this drug is it can cause renal stones, and I've seen it, a couple of times. So you always need to warn the patient about it, and it can increase the intraocular pressure. So you need to warn the patient about changes in the sight. Okay, if they start to have sight changes, they need to stop. Okay, so pyramid has so many roles, and that's why I like to use this, picture here. It can be used in migraine prophylaxis, focal seizures, GTCS, obesity, and so forth. It reduces the body weight. It's one of the drugs used for obesity, by the way. Okay, antiarrhythmic drugs like lidocaine, mexiletine, propranolol, verapamil. The most important one, as far as I'm concerned, is lidocaine. Okay, and then we have, of course, verapamil and propranolol. Propranolol is used as a prevention to migraine headaches, and verapamil, we mentioned this before, it's used as a prevention to cluster headaches. Okay, now lidocaine blocks sodium channel. You can give it, as an infusion. You can give it as a patch. We use it like extensively in regional anesthesia. We use it in even as an IV infusion. During abdominal cases. And we use lidocaine. Nowadays, there are like some literature that it can be used in, palliative setting. There are two Canadian articles about them. Please look them up. I think I put them in the group, but I don't mind to put them back again. This is something that you can use as an adjunct if you're having a palliative patient with an intractable neuropathic pain. The dosing in palliative care, I'm going to tell you the number now and just memorize it because you will not see it in the literature. 200 milligrams. Don't exceed 200 milligrams. Trust me. Okay, because if you're really going to the maximum dose, which is 5 per kilo, in somebody with any liver problem, you might get toxicity pretty easily. So never, for safety, don't go beyond 200 milligram lidocaine infusion. All right, alpha 2 agonist. Clonidine, we use it mainly in, high blood pressure. The nice thing about it, it comes as a patch. So, like in the end of life, I love to use clonidine as to treat the blood pressure, because most of the patients will not be able to like swallow their, tablets and so forth. So it's a very good choice. And you can use it also from, somebody that's, coming off opioids or something, because it has an anxiolytic effect. Okay, now we have something called dextromethorphan, which is an IV medication, and this one is used in anesthesia extensively right now, and you can use it also in palliative setting. All right, for delirium. It has, it doesn't cause respiratory depression like opioids. It does help with pain. The main problem is hypotension. Tizanidine is a muscle relaxant that we use, on daily basis for musculoskeletal problems. So this is tizanidine tablets. It's under many names. Okay, it's also an alpha 2 agonist. Okay, now antispasmodics, we have a huge list, all right, that I put there for you guys. The only one that really restricted is called Carizo Perdol or Soma, very famous in the United States, and its patients abuse it. I mean, big time. Um, then cyclobenzaprine. This is a very important medication. Unfortunately, it's not available in Saudi Arabia. It's available in Egypt, and it's pretty cheap drug. It's very similar to amitriptyline, okay? And maybe this is the reason they didn't approve it in Saudi Arabia. Now, this drug actually very useful in fibromyalgia, okay? So be careful about that. Now, the rest of them, most of them work centrally, okay, except for one drug called dantrolene. We're gonna mention it. Baclofen is an important muscle relaxant. Work on the GABA B. There's an intrathecal form of baclofen that we use it in spasticity, and this is it. Okay, uh, baclofen can be used in hiccups. Can be used as the second uh, choice in trigeminal neuralgia after carbamazepine. Can be used as spasticity. It can be used with gabapentoids, as an adjunct in neuropathic pain. I know a lot of doctors that all they prescribe is gabapentin and baclofen, okay, for neuropathic pain. Now for the pump, we have something called Ashworth scale. Just I don't have time to explain the details, but this scale is we scale used for to monitor the spasticity before and after giving baclofen. Just remember the name right now, and we can discuss it later. Okay, baclofen pump. The guys with rehab, they use this extensively, these baclofen pump for spasticity patients. Riluzole is another muscle relaxant, works also on NMDA, and we use it in ALS. They love it in the palliative exam. It can extend the patient, lifespan up to 3 months. Okay, Riluzole. Dantrolene, it's a muscle relaxant. This is the only muscle relaxant that works peripherally on the muscle itself. It doesn't work centrally. And it's used mainly in malignant hyperthermia and also in Neuroleptic malignant syndrome. You can use it, some people love it to use it like a regular muscle relaxant. But let me tell you, this drug is a little bit harsh on the liver, so you gotta be careful about it. But like in Egypt here, we use it a lot, in the private sector. I don't mind to use it, but use it for short term and monitor, liver function. Okay, antipsychotics. Their role in pain is not very big, except if you have somebody with delirium, okay, or psychosis. All right, um, but you know we use them in other indications like olanzapine. We use it nowadays for appetite stimulation. We use it for delirium and so forth. All right. There's only one study that showed that antipsychotics are useful in dyspnea, and this study never been replicated again. So this is something you might consider, in your for research in the future. Trying, for example, haloperidol for breathlessness. Okay, serotonin agents. We have the most famous ones is somatriptan, um, and also ergotamine and dihydroergotamine. These work on 1D and 1B partial agonists. Okay. Now, the problem with this can cause vasoconstriction, and thus you cannot use them in patients with coronary artery disease. However, there are new drugs right now, serotonin agonists, that work on 1F, okay, as in Frank, 1F. So these are uh, could be used in patients with coronary artery disease. Okay, and as you see, these patients can cause chest discomfort when you inject them in 5% of the population. Of course, also the ergotamine and dihydroergotamine can cause actually, the same problem here. And this is basically the mechanism of action of the triptans. All right, the 1B, 1D. Okay, because as I said, uh, uh, these can cause vasoconstriction to the coronaries as well. They came up with a new drug that works on 1F and doesn't have the side effects. And these are the classification for 5-hydroxytryptamine receptors. Now, uh, uh, recently we have a bunch of medication called the calcitonin gene-related peptide receptor antagonists, and we use them in migraine because we found that the calcitonin gene-related peptide is the most abundant, chemical in the case of migraine here. And as you see, there are a host of these medications on town. Some of them are abortive, some of them are, preventive. The most famous one available in Middle East is this drug called galcanezumab, galcanezumab or Imgalti. Okay, and this drug is available in Saudi Arabia and Egypt. Okay, uh, NMD antagonists. All right. The most important ones that you guys need to know about are the ketamine and methadone. But we have other drugs like dextromethorphan, buprenorphine, amantadine, memantine, and magnesium. These drugs can actually help